Rachel Torres was a ghost, not because she was dead, but because everyone at Memorial Medical Center looked right through her, as if she didn't exist. She'd been working in the emergency department for exactly 2 months and 17 days. Not that she was counting, but she was. In her notebook, the small leather one she kept hidden in her locker, she noted dates, times, staff rotations, patient outcomes, and something else. The patterns, the lies, the incompetence that cost lives. The way Patricia Chen ignored her in the hallways. The way Dr. Calloway seemed to treat nurses like animated furniture. The way Jennifer, who'd been warm on day 1, had become cold after Rachel corrected her medication calculation in front of a patient's family member. No one noticed her noticing. That was the point. Rachel had learned a long time ago that invisibility was a superpower if you knew how to use it. She'd learned it in a place most people would never speak aloud. In the Korengal Valley, in Helmand Province, in underground operating rooms where light came from headlamps, and the floor was dirt and blood, was just another fluid to manage. She'd learned it in desert camps and forward operating bases and inside medical tents, where the sound of helicopters meant you had seconds to save a life before the next crisis arrived. She'd learned it by watching, always watching, seeing what people missed because they weren't paying attention. But that was a different lifetime. The woman standing in the ER break room at 6 in the morning, rewrapping her hands before her shift began, was different. She was smaller now, quieter. Her dark eyes had learned to hold secrets. Her voice had learned to make itself smaller. The scars on her shoulders and arms were covered by long sleeves, even in the summer heat of the hospital. The tremor in her left hand, only noticeable if you were looking, she hid by keeping that hand in her pocket most of the day. She'd become an expert at disappearing into spaces where people looked right past her. Rachel Torres, ER nurse, badge number 4427, was the safest kind of invisible. Until she wasn't. The day started like most days. The fluorescent lights hummed their sick song. The smell of disinfectant and something underneath it, something organic and dying, hung in the air. Rachel had already done 3 impossible things before the morning shift officially started. She'd restarted a patient's IV after 3 nurses couldn't find a vein, working the difficult vein in the forearm like she could read the blood vessels through skin. She'd caught a medication error that would have been fatal, a decimal point in the wrong place that would have given a diabetic patient 10 times the correct insulin dose. And she'd noticed the suspicious bruising on an elderly male patient that suggested internal bleeding from an accident he'd been admitted for observation about. Bruises that formed a pattern that meant something. Nobody asked how she noticed these things. Nobody asked her anything, really. Dr. Brett Calloway swept into the ER at 6:47 a.m. like he owned it. In a way, he did, or at least he acted like it. Harvard Medical School, Yale residency, fellowship in somewhere prestigious that he mentioned constantly. His white coat was pristine. His shoes were polished. His smile was the kind that made people trust him immediately, before they understood that trust was a transaction with Dr. Calloway. You gave him credibility, and he gave you nothing in return. His stethoscope was draped around his neck like a symbol of authority, and his voice carried the confidence of someone who'd never been questioned in his life. "Torres," he said, not looking at her. "Room 412. Change the dressing on Mr. Hansen's wound. And don't be slow about it. I need those results back within 15 minutes. Dr. Calloway, I wanted to mention the elderly patient in 308. I'll handle 308. He said it like she'd been presumptuous to think otherwise. Like a nurse, a handmaiden, really, should not speak unless spoken to. His dismissal was so complete that he'd already turned away before she finished speaking. And Torres, next time, I'd appreciate it if you waited for me to ask for your observations. We have a hierarchy here, for a reason." Rachel pulled her hand from her pocket and simply nodded. Around her, the other nurses were already moving. There was Jennifer, who'd been friendly on her first day, and then cold after Rachel had corrected her medication calculation in front of the patient. There was Marcus, who told jokes Rachel didn't understand, but everyone else laughed at. Jokes that usually ended with someone being mocked for not fitting in. And there was Patricia Chen, the head nurse, who decided within Rachel's first week that she was competition rather than a colleague. Patricia had started as welcoming, but had shifted when she noticed Rachel caught mistakes faster than she did. "Scarecrow's doing the dressing," Patricia said to Jennifer, using the nickname that had somehow stuck. Scarecrow, because Rachel was thin and moved quietly and sometimes stood very still. And apparently, that made her somehow less than. Rachel kept her expression blank and headed toward room 412, already compartmentalizing the insult, filing it away with dozens of others. The thing about invisibility is that it's a two-way mirror. You see everything, and no one sees you. You watch people become versions of themselves they would never admit to in person. You watch good doctors become arrogant because no one challenges them. You watch nurses become cruel to people weaker than themselves. You watch systems fail and people die, and institutions cover it up because the liability is worse than the truth. Rachel had been watching for 2 months and 17 days. She'd been documenting it in her notebook. Mr. Hansen's dressing went smoothly. He was a post-op patient from a routine appendectomy, recovering normally. When Rachel entered his room, he brightened. She changed the dressing, with the kind of gentle precision that came from experience, from years of working on people whose bodies were broken and fragile. She swabbed the incision site with antiseptic, examined the wound for signs of infection, checking for erythema, drainage, any indication that the healing wasn't progressing correctly, and carefully applied the new dressing. "You're good at this," Mr. Hansen said, holding her hand as she worked. "Better than the others. Gentler. The way you touch the wound, it's like you know exactly what it needs." Rachel didn't tell him that she'd managed shrapnel wounds in places where infection meant death. She didn't tell him about the field hospital in Helmand Province, where she'd learned to recognize the subtle signs of wound compromise with her eyes closed. She just smiled softly and said, "Just practice, Mr. Hansen. How are you feeling today? Any pain? Nausea?" "Good," he said. "Really good. You should be the head nurse here, you know that? You're better than Patricia." Rachel didn't respond to that. She just continued her assessment, checking his vitals, making sure everything was tracking correctly. The beeping monitors, the soft hum of the IV pump, the quiet sounds of care. This was her domain. This was where she could disappear into the work. By 10:30 a.m., the ER had found its rhythm. The morning admissions were stable. The traumas from overnight had either improved or been transferred upstairs. The lull. The calm before whatever came next. Rachel restocked the trauma bay with methodical precision, arranging the decompression kits, organizing the surgical trays, checking the medication cart, making sure the advanced airway equipment was ready. Laryngoscopes, endotracheal tubes, bougie guides, all in their proper places. Small things, invisible things, things that mattered. She worked with the kind of efficiency that came from having done these things 1,000 times in places where lack of preparation meant someone died. It was 10:47 a.m. when the red phone rang. Not a regular ring. A special one. The one that meant something serious had happened. An emergency announcement system that was used only when the situation was critical. Rachel's hands went still. The phone was at the main desk. Patricia picked up, and Rachel could see the moment her face changed. "Memorial Medical, this is the emergency department," Patricia said, her voice shifting into professional mode. Rachel watched the nurse's face, reading the micro-expressions: concern, surprise. Then that shift into command mode. "Copy, mass casualty. How many?" Patricia asked, her voice climbing slightly. "Multiple victims? What's the ETA?" "Copy that. We're initiating protocols now." The words hit the ER like a shockwave. Every nurse in the ER moved at once. Rachel moved with them, but she'd moved like this before. In a different place, under different skies. When mass casualty meant the convoy had hit an IED, or the compound had been breached, or the village that was supposed to be safe was anything but. She knew what it meant to have 15 minutes to prepare for chaos. "Priority incoming," Patricia called out, her voice taking on the tone of someone in command. "Trauma Bay 1 and 2, all available staff. Everyone else, prep isolation. This is going to be bad. Movement now. Move." Dr. Calloway emerged from his office with the expression of someone about to be famous. He loved these moments. Rachel could see it in the way he straightened, the way he positioned himself to be at the center of the action. "I'm taking point on this," he announced, his voice loud enough for everyone to hear. "Everyone follows my lead. Standard mass casualty protocols. This is a teaching moment for everyone here. Watch and learn." Rachel had memorized those protocols her first week. They were adequate. They were also written by people who'd never actually had to perform them under conditions that mattered. She went to the trauma bay and began her checklist with the speed of long practice. Trays prepared. Trauma tray 1 with instruments for wound exploration and hemostasis control. Blood products requested: O negative blood, plasma, platelets. All the components of a massive transfusion protocol. Oxygen running at full capacity through multiple delivery systems. Monitors set and ready. Equipment positioned. Defibrillators, ventilation bags, suction equipment all in place. She worked with an efficiency that was, to anyone watching, just another nurse doing her job. But her hands were remembering something else. Her hands were remembering the medical tents in the Korengal Valley. The smell of dust and blood. The constant pressure of more patients than beds, more wounds than supplies. Her hands were remembering how to save lives when time was the only resource that mattered. The helicopter appeared on the monitors first. The receiving notice came through while the sound was still distant. But Rachel heard the rotors before the radio update came. She'd know that sound in her sleep. That distinctive rhythm of the MH-60 Blackhawk, the bird that had carried wounded soldiers in and out of forward operating bases thousands of times. Military transport. Which meant the incoming patient wasn't a typical civilian trauma. "Military patient inbound." The radio crackled. "Gunshot wound to left chest, penetrating trauma, unstable vitals. Approximately 4 hours from time of injury. ETA 3 minutes. Patient is a colonel rank officer. Military medical team accompanying. Stand by for priority VIP briefing." The radio cut to static. Patricia's eyes went wide. A colonel. Military. This was already becoming a different kind of situation. This wasn't just a patient. This was a code black. This was the kind of patient that brought attention, that brought complications, that brought power structures other than the hospitals. The helicopter landed on the pad adjacent to the ER. Through the windows, Rachel could see the tarmac begin to shimmer from the rotor wash. The heat waves rising up. Equipment was visible, military-grade trauma gear that was significantly better than half the stuff they had here. IV lines with combat medicinal infusions. Tourniquets applied with military precision. Compression bandages wrapped to specification. And soldiers, not civilians. not security. Combat personnel in multicam tactical gear, weapons visible at their sides, moving with the precision of people trained to operate in hostile environments. Special operations personnel, the kind of soldiers who trained for years to work under exactly these conditions. This was a Code Black, a VIP patient, someone important enough to warrant a military escort into a civilian hospital and enough authority to bring that perimeter with them. The gurney rolled through the ambulance bay doors like a crisis compressed into metal and wheels. The patient was covered in tactical dressing, compression wounds, tourniquets applied at exactly the right tension. Combat issue field medicine that represented thousands of dollars of specialized equipment. There was military blood on the sheets, and the medical team surrounding the patient moved with the coordination of people who'd done this before. Not here. Somewhere else. Somewhere worse. The Middle East, Afghanistan, places where this was routine. Rachel got a glimpse of the patient's face as the gurney moved past, and something shifted inside her. Her breath caught, her hands stilled for a moment. She knew him, not from here, from before. From a different lifetime, when she'd worn different clothes, gone by a different name. His name was Captain James Morrison, call sign Reaper in his unit. Though not because he killed, because he understood death intimately and could pull people back from the edge better than anyone else. The last time she'd seen him, she'd been stabilizing a sucking chest wound in a tent while mortars landed outside. The sound of the explosions shaking dust from the canvas above them. That was 15 years ago, and he had a scar on his left jaw that matched the one she remembered, a mark from when shrapnel had torn through a convoy and left him bleeding out on the road. "Bay 1, Doctor." Calloway called, already positioning himself at the head of the patient, with the confidence of someone who'd never doubted his own expertise. "Let's see what we're working with. Trauma surgery standing by? I need an open assessment of thoracic trauma." "Trauma surgery is 3 minutes out," someone confirmed. "They're coming down from OR now." Rachel moved into position, her hands moving through muscle memory that had nothing to do with 2 months at Memorial Medical Center. She was already assessing, Glasgow Coma Scale checking the patient's neurological status, skin color reading the level of shock, respiratory effort determining the work of breathing, bleeding control identifying where the greatest threat was. The military medic who'd brought him in was already giving report, his voice steady, his assessment precise. GSW to left chest, approximately 4 hours ago. Point of injury was urban environment, approximately 3 blocks from military compound. Patient was engaged in security detail. Entry wound is mid-left anterior, below the nipple line. No exit wound visible. Field treatment protocol. Immediate compression dressing applied, arterial tourniquet applied to left arm as precaution, 2 liters normal saline administered intravenously, epinephrine administered once for cardiac support. Patient was stabilized and transported via Blackhawk medevac to forward surgical team. At FST, patient received additional 2 liters fluid resuscitation, vital signs stabilized enough for transport. Last vitals en route. BP 92/56, HR 138. Respirations shallow and labored at 16 per minute. Field assessment indicated possible tension pneumothorax based on tracheal deviation observed. Needle decompression performed with partial response. Patient's condition has been trending unstable since flight. We suspect the decompression was only temporary, and the pneumothorax may be reaccumulating. Tension pneumothorax. The kind of injury that kills you in minutes if you don't understand what you're looking at. Air in the pleural space, accumulating with every breath, collapsing the lung, compressing the heart, cutting off venous return. The mediastinum shifted. The superior vena cava compromised. Oxygenation and perfusion both failing simultaneously. It looks like certain things. It has patterns. It has tells, if you know what you're looking for. Dr. Calloway was already barking orders, positioning himself as the authority in the room. But Rachel was watching the patient's vitals. The numbers told a story that contradicted what Calloway was saying. Oxygen saturation, 94%, but trending down. Heart rate, 142 and climbing. Blood pressure, 90/52, dropping slightly. Respiratory rate, 18 and rising. The pattern was unmistakable to someone who'd seen it before. Looks like cardiac trauma, Calloway announced with certainty, not asking questions, not considering alternatives. Gunshot wound to the chest, unstable vitals, definitely cardiac involvement. We need an emergency pericardiocentesis. Get me a needle, let's tap the heart and see if there's fluid. Prepare for emergency thoracotomy. We might need to go straight to OR. Rachel's hands went still. The vitals didn't support cardiac tamponade. The JVD, jugular venous distension, wasn't there. Not the massive elevation you'd see if the pericardium was compressing the heart. The muffled heart sounds were minimal. The pattern she was seeing was different. Completely different. The lung sounds on the left were absent, completely silent, which meant the lung had collapsed. The trachea was straight, not deviated away from the injury site, which ruled out massive tension. The neck veins were elevated, but not in the pattern of cardiac compression or massive venous obstruction. This was a tension pneumothorax. And if Calloway performed a pericardiocentesis on a patient who didn't have fluid in the pericardium, he'd waste precious minutes while the patient deteriorated. Minutes the patient didn't have. The oxygen saturation was already at 91% and dropping. The heart rate was climbing. The blood pressure was falling. This patient was circling the drain, and Calloway was about to make it exponentially worse. She shouldn't say anything. She was invisible. She was a scarecrow. She was a nurse who'd been fired in her last 2 positions for overstepping and not knowing her role. She'd learned the hard way that the hospital hierarchy was not a place where nurses challenged doctors, no matter what the evidence suggested. But the patient's oxygen saturation hit 89%. The heart rate climbed to 156. The blood pressure dropped to 84/48. The patient's skin was turning gray. The patient was circling the drain, and Calloway was about to perform a procedure that would do the opposite of what was needed. Rachel watched a man she'd once pulled out of a burning vehicle begin to die because of a diagnosis that was wrong. She made a choice. It wasn't the choice of a person trying to keep their job. It wasn't the choice of someone concerned about hierarchy or protocol or the career implications of challenging a Harvard-educated attending physician. It was the choice of someone who'd learned long ago that sometimes you have to break the rules, because the rules are written by people who've never had to actually live with the consequences of breaking them. She'd made this choice before. In the desert, in the mountains, in places where the penalty for being wrong was death. "Step aside, doctor," Rachel said. The words came out quiet, but there was something underneath them, something that came from a different time, a different life, something that made people listen even when they didn't understand why. It was the voice of someone who'd given orders that people had obeyed because their lives depended on it. "Excuse me?" Calloway's voice dripped venom. "You do not speak to me like that." Tension pneumothorax, second intercostal space, mid-clavicular line, 14-gauge angiocath. He's got maybe 90 seconds before his heart stops, and you can't restart it. "You're a nurse, not a doctor. You don't have the training to..." Rachel was already moving. She'd already grabbed a 14-gauge angiocath from the tray. She'd already swabbed the second intercostal space with alcohol, creating a sterile field. She'd already positioned her hand like her muscle memory was screaming for her to do. Thousands of hours of training compressed into pure reflex. Her hands knew this procedure better than she knew her own name. "Do not touch this patient," Calloway said, his voice rising, his face flushing with rage at being questioned. "Security. I need—" Rachel inserted the angiocath. The needle slipped through skin with its characteristic resistance, through fascia, through the intercostal muscles, through the parietal pleura, and into the pleural space. There was the sensation of the needle breaking through. That specific resistance that meant you'd reach the other side, the sensation that said you'd breach the boundary. She advanced the catheter and withdrew the needle in a smooth motion, a procedure she'd performed so many times it was second nature. The sound that came next was unmistakable. The sound of 8 atmospheres of pressure equalizing. The sound of air that had been compressing a man's heart suddenly releasing into the room. The sound of 8 atmospheres of pressure that had been keeping the patient's lungs collapsed and his heart compressed, suddenly venting to atmosphere. A long, perfect hiss. Like a tire deflating. Like pressure releasing. Like salvation. The monitors changed immediately. The oxygen saturation climbed. 84, 86, 88, 90. The heart rate dropped from 156 to 134 to 119. The blood pressure rose from 84/48 to 92/58 to 98/64. The patient's chest rose and fell with purpose again, with actual ventilation rather than the futile struggling he'd been doing. The color returned to his face. The vital signs that had been plummeting suddenly reversed the course. The tension pneumothorax decompressed with a single procedure performed by a woman everyone had decided wasn't important enough to listen to. "Get me a chest tube," Rachel said, already positioning the next step, her voice steady and commanding. "We need to get a large bore chest tube in there and secure it properly. Trauma surgery should be ready. We need an operating room prepared for thoracotomy. This patient needs surgical exploration of the mediastinum and assessment of the great vessels." Calloway's face had gone purple. Not red, which might suggest anger. Purple, which suggested actual apoplexy. His jaw was clenched. His hands were shaking. "You're done," he said, his voice cold and lethal. "Security. Get her out of my ER, now, and file charges. Practicing medicine without a license, assault on a patient, insubordination, everything you can think of." The thing about being invisible is that you can see the moment when people realize they've been looking at you wrong the whole time. But you don't stay around for it, usually. You leave. Rachel was leaving. Security came to the trauma bay. 2 men, embarrassed, caught between the authority of a doctor and the reality that they'd just watched a nurse do something miraculous. They'd both seen the monitor change. They'd both heard the sound of the decompression. They understood, on some level, what had just happened. One of them took Rachel's arm, gently, almost apologetically, his touch saying what his words couldn't. She didn't resist. She never did. Resistance was pointless. She'd known from the moment she made the choice that this would be the outcome. "You'll be hearing from our lawyers," Dr. Calloway was saying, directing his words at her as security was already escorting her away. "Practicing medicine without a license, assault on a patient, violation of hospital protocol. You'll be lucky if you ever work in a hospital again. I'll make sure of it." Rachel was already walking out of the trauma bay, through the ER, past the other nurses who were watching with a mixture of shock and something that looked like recognition. Patricia's face had gone gray. Jennifer was covering her mouth. Marcus was staring at the patient, already checking his vitals, already adjusting the oxygen, already doing the work that needed to be done now that the immediate crisis had been averted. The medical staff would do the rest. The procedure would be completed. The patient would survive. And Rachel would be gone. Rachel was being escorted out of the hospital, through the main entrance, and across the parking lot. The security guard let go of her arm once they were outside, in the afternoon sun, where the air was warm and clear. "For what it's worth," he said quietly, his voice genuine. "That was incredible. That was the most incredible thing I've ever seen." Rachel didn't respond. She was already reaching into her locker in her mind, mentally gathering her few personal items. Her spare scrubs, the notebook, the 5 photographs she kept hidden in the bottom. This job was over. This identity was burned. She'd done it before. She could do it again. She walked. The hospital was in downtown Portland, a few blocks from the Willamette River, and Rachel walked toward it without really thinking about where she was going. Her hands were steady now. The tremor was gone completely, burned away by adrenaline and action. Her heart rate was controlled. Her breathing was regulated. The shock of what she'd done and what it would cost was compartmentalized, filed away for later processing. She'd learned to do this long ago, to separate the emotional reality from the immediate necessity of moving forward. She'd done it before. She'd burn them down if it saved a life, then walk away from the ashes. She'd walked away from burning buildings, from hospitals, from identities. The skill had become automatic. It was 11:03 a.m. when she heard the helicopters. Not one. 2. Coming in fast, their rotors cutting the air with a rhythm that was unmistakably different from the medevac bird that had come in earlier. These were military birds. MH-60 Blackhawks, both of them moving in formation, and they weren't slowing down for the helipad. They were coming in hot, their approach rapid and deliberate. Rachel stopped walking. Her mind was already processing the implications. The rotor wash was hitting even from a distance, the mechanical force of the rotors pushing air outward in concentric circles. The downtown buildings channeled the sound, amplifying it, making it echo off concrete and glass. Her dark hair was streaming behind her in the wind from the rotors. The sound was so loud, it echoed off the buildings around her. A physical force that you didn't just hear, but felt in your chest. The helicopters banked toward the hospital. They began to descend toward the parking lot, the ER entrance area, the tarmac where the earlier bird had landed, not the helipad, the parking lot, the open area. They were landing directly at the hospital, establishing a presence that was unmistakably military. And Rachel understood. Code Black, VIP patient. But this wasn't about the patient anymore. This was about something much larger. This was about command structure. This was about authority. This was about whatever chain of command those soldiers answered to, having decided that this situation was important enough to bring 2 operational helicopters to a civilian hospital in the middle of the day. She kept walking. Behind her, the landing zone exploded into activity. The rotor blades hit their final approach speed, the rotors slowing to prepare for landing. The wash became a visible force, moving trees, throwing debris, sending papers and leaves and loose objects spiraling into the air. Rachel could hear shouts, military voices, trained and precise, calling out positions and perimeters. Move left, clear that vehicle. Establish perimeter, establish perimeter. Check those windows, check for hostiles. Weapons being readied. Tactical gear hitting the pavement as soldiers rappelled down from the aircraft. A security perimeter being established with military precision. The noise was immense. The ground shook with the vibration of the rotors. The afternoon sun was blocked out by the helicopter's shadows as they descended. The rotor wash created a maelstrom around the hospital. visible as a distortion in the air, as waves of heat and wind. Rachel didn't look back until she was at the corner of the street, about a block away. Her pace never changed. She didn't run. She didn't hurry. She just kept walking with the steady pace of someone who was walking away from something rather than toward somewhere. What she saw was a hospital suddenly transformed into a forward operating base. Soldiers in multicam tactical gear, the pattern of greens and browns designed for desert environments, were establishing a perimeter around the building. Not local law enforcement, not hospital security, not Portland police. Military personnel with weapons visible, with tactical vests, with the bearing of people trained to operate in hostile environments. Special operations personnel, Rangers, SEALs, or worse. The kind of soldiers who specialized in taking control of situations that nobody else could handle. The civilian staff of the hospital were being moved away from the entrance. The loading zone was being secured. Barriers were being established. This wasn't just a medical evacuation. This was a military operation happening at a civilian hospital. Rachel turned the corner and kept walking, but she could still hear the chaos behind her. Shouting, orders, something official and enormous and implacable, descending on the hospital like Judgment Day. She could hear the soldiers calling to each other. She could hear commanders giving orders. She could hear the coordination of a well-trained military force establishing control of a space. She'd made it 2 more blocks when she heard the command. Stop. Not a question. Not a request. A military command, delivered through a loudspeaker by a voice that had spent decades making people do exactly what it said. The kind of command that expected obedience, that knew it would get obedience, that carried the weight of absolute authority. Rachel stopped. A tactical vehicle pulled up beside her, moving with the deliberate precision of a military operation. No markings. Matte black paint, non-reflective. Soldiers visible through the tinted windows. Enough of them to suggest this was serious. The rear door opened with a hiss of hydraulics, and she found herself looking at a man who was approximately 45 years old, 6'3", with the kind of posture that came from a lifetime of command. His bearing was immediate. His presence was unmistakable. His face was scarred, old burns on the left side, partially healed, the kind of scar that said he'd been close to an explosion and survived it. Not a small explosion, a significant one, the kind of blast that killed most people. His eyes were ice blue, and they were looking directly at her with the intensity of someone who had just found something he'd been searching for. "Rachel Torres," he said. It wasn't a question. "Yes, sir," Rachel said. 30 years of habit made her answer correctly, her voice steady, her posture correct. "Get in the vehicle." She got in the vehicle. The door closed behind her with a solid mechanical sound. The vehicle began moving immediately, accelerating, heading back toward the hospital. Rachel sat in the back with 2 soldiers flanking her, their weapons visible but not threatening. She understood the message. This wasn't a kidnapping. This was custody. This was something official and larger than she could process in the moment. The scarred man didn't speak. He just watched her with those ice blue eyes, as if confirming something he already knew. The command center had been established in the hospital's main conference room in approximately 20 minutes. Rachel was ushered upstairs with 2 soldiers flanking her, escorted through hallways that had suddenly become military space. The civilians who'd been working here were being quietly moved out of the building. Hospital staff were being confined to their departments. An entire floor had been sealed with soldiers at the stairwells and elevators. This wasn't just a code black anymore. This was an active military operation. The man with the scarred face was waiting in the conference room when Rachel arrived. A tactical team flanked him, soldiers in positions that suggested they were prepared for anything. Maps were on the table. Not of Portland, but of regions Rachel recognized immediately. The Korangal Valley, the Hindu Kush Mountains, Kandahar, the Helmand Province, Panjshir, the places she'd trained, the places she'd survived, the places where she'd learned to keep people alive in conditions that shouldn't have kept anyone alive. "Sit," the man said. Rachel sat. The soldiers remained standing, positioned around the room. "I'm Commander Marcus Webb," he said. "Special Operations Command, Central Command. I'm going to make this quick because time is something we don't have. And I'm going to speak plainly because there's no point in being anything else." He pulled out a folder. Inside were photographs. Rachel couldn't see them clearly from where she sat, but she didn't need to. She already knew what they showed: her military medical file, her records, her history, everything that she'd tried to disappear from. "Captain James Morrison came to our medical facility in Kuwait 3 hours ago with a gunshot wound to the chest," Webb continued. "The military medics there managed his trauma, very professionally, I might add. But they couldn't complete the surgery he needed. He needed a facility with surgical capacity, with imaging, with the ability to handle complications. We had to transport him here, to Memorial Medical Center, to what we thought was a civilian hospital that would provide appropriate care." Rachel nodded slowly, understanding the subtext immediately. The receiving team at this hospital put him in the care of a doctor named Brett Calloway. According to the records we pulled in the last 30 minutes, Calloway was about to perform a pericardiocentesis for suspected cardiac tamponade, a procedure that would have killed your patient in under 4 minutes because he didn't have a tamponade. He had a tension pneumothorax. "Yes, sir," Rachel said quietly. Instead, a nurse named Rachel Torres walked up to that trauma bay and performed a needle decompression for tension pneumothorax. She did it without permission. She did it without the attending physician's approval. She did it based on her own assessment of the patient's condition. And she was right. Webb leaned forward, his ice-blue eyes locking on hers with the intensity of a man who was about to say something important. "The X-rays from our team confirm it. Tension pneumothorax, exactly where she said it was. The decomp was textbook. Perfectly executed. The patient is stable now. The surgical team is prepping him for a chest tube, for thoracotomy, for reconstruction surgery. He's alive because you knew exactly what you were looking at." He pulled out another file. This one was older. The photographs were older. The paper was slightly yellowed. Rachel knew what was in it before he opened it. Her life, the part she'd tried to bury. "Rachel Torres joined the Navy in 2003 at age 17, Webb continued, reading from the file, his voice steady. "She completed basic medical training in 2004. She was attached to a Special Operations medical team in 2005. She served in the Korangal Valley from 2006 to 2007. She was part of the Panjshir Valley operations in 2007 to 2008. She was stationed in Helmand Province from 2008 to 2010. During her service, she operated in forward medical positions, in combat situations, in conditions that would have broken most people." Webb's ice-blue eyes locked on hers. She received the Navy Cross in 2008 for extraordinary heroism in combat. She received 2 Silver Stars. She was hit by shrapnel twice, shot once, exposed to multiple IED blasts. She stabilized more than 400 military personnel in the field with a survival rate of 98%. 98%. Do you understand what that means? That means she was better at keeping people alive in the worst possible conditions than surgeons in hospitals with all the equipment in the world. Webb closed the file. She was trained in emergency procedures by some of the most elite combat surgeons in the military. She was given skills that took other doctors decades to develop. And then, in 2011, she requested discharge and disappeared. No forwarding address, no contact with the command structure, no warning. She just walked away from a 10-year commitment and disappeared. Rachel didn't move. She didn't respond. "We called you Reaper," Webb said. "Not because you killed, but because you pulled people back from the edge of death. You operated in conditions that would have destroyed most people. You made decisions in seconds that doctors with years of training couldn't have made. You became legendary. Your name was known in every special operations unit from Iraq to Afghanistan. When young medics were training, they wanted to be like you. When command wanted to know if someone could handle extreme conditions, they asked if they had Reaper's training." He closed the file and set it on the table. "So, my question is simple. Why are you working as a nurse in a civilian hospital, getting bullied by an idiot from Harvard, when you're one of the most skilled emergency medical personnel I've ever known?" Rachel looked at the table, at the files, at the weight of her past. "I wanted to disappear, sir," she said quietly. "I wanted to be normal. I wanted to not be the person who'd killed people. I wanted to not be the person who'd made decisions that cost lives. I wanted to not be the person who could function when other people were falling apart." "You're not normal," Webb said. "You never have been, and you never will be." He stood up, his massive frame suddenly dominating the space. "Captain Morrison is asking for you. He remembers you. He knows exactly who you are and what you did for him back in the Korengal. He needs surgery, and he wants you there. He doesn't want a trauma surgeon. He wants you, because you're the person he trusts to keep him alive." Rachel looked at the table, at the evidence of who she'd been, at the weight of what that meant. There's also the matter of this hospital's administration, their attending physicians, and the decision to cover up medical malpractice. We have lawyers and federal authorities inbound. We have the FBI looking at fraud. We have the state medical board preparing to revoke licenses. Dr. Calloway is going to spend the next several years explaining to everyone why he nearly killed a government official. And more importantly, explaining why he would have killed him if you hadn't broken protocol. Webb extended his hand across the table. "So here's what's going to happen. You're going to come with me. You're going to do what you do better than anyone else in the world. You're going to help your friend stay alive. And then we're going to have a very serious conversation about what comes next." Rachel looked at his hand. She thought about the woman who'd wanted to be normal. She thought about the ghost who'd tried to disappear into the fluorescent lights of a hospital where no one saw her. She thought about the scars on her shoulders that she hid. She thought about the tremor in her hand that she'd been learning to control. She thought about the last 15 years of trying to bury who she'd been. She thought about Captain James Morrison, 15 years in her past, who she'd pulled back from the edge when everyone else had given up. She took his hand. The surgical suite on the hospital's 4th floor had been transformed completely. Military surgeons in addition to the hospital's trauma team. Specialized equipment brought in by helicopter. Surgical instruments refined specifically for combat medicine, diagnostic tools beyond what a civilian hospital normally had. Protocols that weren't civilian protocols. Military field surgeons who'd operated in the most austere conditions, who'd saved lives when the conditions made it seem impossible. And Rachel, scrubbed in, positioned at the patient's side where she needed to be. Captain Morrison was sedated, already intubated, already prepped. The chest incision revealed the damage. The bullet had traveled through the lung tissue, nicking the pulmonary artery, and come to rest millimeters from his heart. It was the kind of injury that killed most people in seconds. The kind of wound that should have been unsurvivable. "He's stable for now," the trauma surgeon said, his voice careful. "But any manipulation risks exsanguination. The bullet did significant damage to the hilum. Any attempt to remove it or repair the artery without absolute precision and absolute control could result in catastrophic hemorrhage." Rachel looked at the wound. She'd seen hundreds like it. She'd repaired dozens. She could see the trajectory of the bullet, the tissue damage, the viable structures, and the ones that were too compromised to save. She could see exactly what needed to happen. "We need to approach from the anterior," she said quietly, her voice steady, her words precise. "The bullet is too close to the hilum to access from a traditional posterolateral thoracotomy. If we come from the front, through the mediastinum, we have better visualization and better access to the artery. We can control the vessels proximal and distal before we manipulate anything. We can work methodically. We can save him." The trauma surgeon looked at her like she'd suggested something insane. "That approach is textbook field medicine when you're trying to save someone who should already be dead," Rachel said. "I've done it 14 times. 14 gunshot wounds with this exact trajectory. Never lost a patient with this exact wound profile." Webb was watching from the observation window. He nodded once at the surgeon. The trauma surgeon deferred to Rachel's expertise. What happened over the next 2 hours was a masterclass in medical precision under impossible circumstances. Rachel talked the surgical team through each step. She identified the structures. She guided the approach. She managed the bleeding. She worked with the kind of certainty that comes from having done impossible things in places where failure meant death. The anterior mediastinal approach, the careful dissection of the parietal pleura, the identification and isolation of the left pulmonary artery, the branch that was damaged, the careful application of vascular clamps, the assessment of the bullet wound, the precise repair of the artery using fine suture technique. At one point, the patient began to bleed uncontrollably from the pulmonary artery repair. The monitors screamed alarms. The blood pressure dropped. The heart rate climbed. The oxygen saturation fell. It was the kind of moment where things went one of two ways. Either they controlled the bleeding and the patient survived, or they lost the patient on the table. "Vascular clamp," Rachel said calmly, her voice steady, her hands steady. 2 millimeter right angle. I need to isolate the distal end, and I need suction. More suction. I need to see the repair site. Her hands moved with the precision of a craftsperson working in their domain. She isolated the bleeding vessel. She clamped it. She reassessed the damage. She repaired what could be repaired and accepted what could not. She worked through the complication with the kind of methodical precision that said she'd done this before. She had. Intense. In darkness. In places where blood loss meant death and there was nobody else to save the patient. 40 minutes later, the bleeding was controlled. The wound was closed. Captain James Morrison was alive, stable and breathing on his own. Rachel stepped back from the table. "Good work," the trauma surgeon said. It wasn't quite an apology, but it was close. It was the closest thing to an apology that a surgeon could give when they realized they deferred to someone who was right when they could have been wrong. "He's going to make it," Rachel said. "He's going to be fine. The repair is solid. The vital organs are intact. He'll survive this." The aftermath happened in layers, each one exposing a deeper level of dysfunction and corruption within the hospital system. First, the federal investigation into Memorial Medical Center. Lawyers arrived within the hour. Federal authorities. The FBI hospital administration was cordial until they weren't. Then they were devastated when they understood the full scope of what had been exposed. Dr. Brett Calloway's medical license was suspended pending review. The review, everyone understood, was going to end his career. Hospital records were seized. A pattern of medical negligence spanning years was uncovered. Shortcuts, misdiagnoses, patients who died or been harmed because of arrogance and incompetence, and a system designed to protect the powerful at the cost of everyone else. Patricia Chen was placed on administrative leave after it was discovered she'd been directing staff away from Rachel since the beginning, following instructions from Dr. Calloway to watch the new nurse and report on anything she did that could be used against her. She'd been part of the system that tried to silence the person who knew better. The hospital administration offered Rachel her job back, with full reinstatement, a significant settlement, and an apology that dripped with desperation and fear of what the federal investigation was going to uncover. They wanted her to stay. They wanted her to be complicit in the cover-up. She declined. On the 4th day after the surgery, she was called to a private room in the hospital where Captain James Morrison was recovering. He was in a regular hospital bed, the post-op tubes removed, the machines beeping quietly. He looked smaller than she remembered, but his eyes were the same. Sharp, intelligent, alive. "Torres," he said. His voice was still rough from the breathing tube, his throat sore from intubation. "I heard you saved my life." "You were already saved," Rachel said. "I just finished what started." "Bullshit," Morrison said, a smile creeping across his face. "I heard what Dr. Harvard asshole was about to do. I heard what you did. I remember you now. The Korengal. You pulled me out of that village after the IED hit. You worked on me for 6 hours straight while mortars landed around us. You never slept. You never gave up. You kept talking to me even when I was unconscious. You told me stories. You kept me connected to consciousness just through the force of your will." "That was a lifetime ago," Rachel said. "Doesn't matter. A lifetime ago or yesterday, you're the same person. You're the person who won't let people die." Commander Webb appeared in the doorway. "We're ready when you are," he said. Rachel looked at Morrison, then at Webb, then back at Morrison, who was watching her with an expression of gratitude and understanding. "What happens now?" she asked. "Now," Webb said, "you have choices. We'd like you to come back. Not as military. You're a civilian now, and that's what you wanted. But as a consultant. We have medical teams across the world that could use someone with your skills, your experience, your judgment. We'd pay you extremely well, and you'd have complete autonomy. You'd work when you want, where you want, how you want. You'd be a resource, not a soldier." "Or?" Rachel asked. "Or you walk away," Webb said. "You disappear again. You work anywhere you want. You live any life you want. We'll make sure the federal investigation is clean, that your record is clear, that no hospital ever questions your credentials again. You can live your quiet life. You can be normal if that's what you want. We won't stop you. We owe you that much." Rachel thought about the ghost. The scarecrow, the invisible woman standing in the fluorescent light. She thought about the notebook she kept hidden. She thought about the life she'd been trying to build. "I need to think," she said. 6 months later, the policy came down. The Torres medical protocol, named after Rachel, mandated that hospital staff at every major medical center be trained in field emergency medicine. It required that nurses and junior staff be empowered to challenge attending physicians in cases of suspected diagnostic error. It required formal documentation of the challenge and a formal response from the attending. It created a structure where the hierarchy didn't mean that only the person at the top could be right. The protocols saved lives in the first year alone. Multiple patients were identified with misdiagnoses before they could be harmed. A culture of accountability began to form, slowly, carefully, but definitively. The arrogance that had killed patients in the past was being replaced with a system that valued expertise wherever it came from. Rachel read about it from a distance. She'd accepted neither of Webb's offers. Instead, she'd founded a clinic, a small one, in a neighborhood that hospitals had written off, working 14-hour days, 6 days a week. She trained nurses who'd experienced trauma themselves, veterans, people who'd been in combat, people who understood pressure. She worked with homeless populations and veterans struggling with invisible injuries. She worked with people nobody else wanted to work with. She didn't advertise. She didn't network. She just did the work. The clinic became legendary in its own way. Word of mouth, reputation. People found her because they'd heard about her from someone else who'd been saved. Sometimes, late at night, when her hands trembled from the weight of too many people depending on her, when the exhaustion of caring for people without resources made everything feel impossible, she'd sit in the back office and write in her notebook. Not dates and times anymore. Stories. The woman she'd been in the Korengal. The woman she'd been in the hospital. The woman she was becoming. The ghost was becoming real. One afternoon, a man walked into her clinic. He was in his 70s, with kind eyes and a bearing that suggested former military. He asked to speak with Rachel, alone. His voice was quiet but carried absolute authority. The staff understood and left them alone. "I served in the same regions you did," he said when they were alone. "Different unit, different era. Parachute Regiment, 1990s, Bosnia and beyond. But I saw what you did for people. I heard the stories. We all did. In every unit from here to Baghdad to Kandahar, they knew about Reaper. They knew what you could do." Rachel didn't respond. "I want you to know something," he continued. "The military thinks of you as the one who got away. But you didn't get away. You just changed theaters. You're still fighting. You're still saving lives. You're still the person you were in the Korengal. You're just doing it differently now. And honestly, I think you're doing more good here than you ever could in uniform." He stood to leave. "They're proud of you," he said. "All of them. Every person you pulled back from the edge, every life you saved. They're proud." Rachel watched him leave, tears in her eyes for the first time in years. That night, she looked at her hands. The tremor was gone. It had been gone for months, she realized. When had that happened? When had the ghost become solid? Somewhere in the process of helping other people, somewhere in the act of doing the work that mattered, she'd stopped being invisible and started being present. She thought about the video the hospital had released. Footage of her in the trauma bay. The moment she'd inserted the needle. The perfect, precise movement. The way the monitors had changed immediately. The way she'd saved a life while everyone watched. It had gone viral. Nurse saves patient's life against doctor's orders. Hidden military hero exposed in hospital ER. Woman with secret military past defies hospital authority to save colonel's life. The comments were divided. Some people thought she was a hero. Some people thought she'd overstepped and violated the chain of command. Some people thought the whole thing was fake. Some people called her reckless. Some people called her a legend. She didn't read the comments. She didn't want to be famous. She'd never wanted to be famous. She wanted to be invisible while doing impossible things. But invisibility, she'd learned, wasn't about being unseen. It was about being present but not performed. It was about doing the work because the work mattered, not because anyone was watching. It was about integrity, about choosing to be honest, even when honesty cost everything. Rachel Torres, 38 years old, stood at the window of her clinic and looked out at the city below. Somewhere in the darkness, there were people suffering. There were people dying. There were people who would make it because of the work she did, and most of them would never know her name. The ghost was alive, and she was finally at peace with that. Somewhere in a building thousands of miles away, Commander Webb read the annual report from the clinic. He saw the patient outcomes. He saw the medical training programs Rachel had started. He saw the impact spreading outward in widening circles. He saw the Torres medical protocol being adopted in hospitals across the country. He saw the legacy building. He smiled. Some people were meant to save the world from the front lines. Some people were meant to do it from the shadows. Rachel Torres was doing what she'd always done, the work that mattered, the way it needed to be done, without needing anyone to witness it. That was her superpower. Not invisibility, integrity. For you watching this, if you were Rachel, what would you do? When you knew something was wrong, when people had power over you, when speaking up could cost everything, would you let it go? Or would you speak the truth, knowing the cost? The comments are open. Tell me your story. And if you know a Rachel, a person with quiet strength, hidden depths, and the courage to speak up when it matters most, tell them. Tell them we see them. Tell them the work they do matters. Tell them they're not invisible, even if the world treats them that way. Thank you for watching Code Whisperers. We'll see you in the next story.